Okay, hi everyone. I hope this is, as Chrissy said, this is a follow-up to a talk I gave in January, um, which introduced process mining and tried to make the case that process mining was an important prerequisite before diving in and starting to do AI. As you know, lots of people are trying to do AI in all sorts of places in the NHS, and I tried to argue last time that understanding what the processes are in our complex healthcare systems is important before we kind of try and see how we can make them better. Anyway, so the brief for this one was, well, primarily aimed at people that came last time, but I've done a kind of recap as well, which I hope will be an intro for those people that missed the previous session. So Chrissy's brief, I think, was, could you be really, really technical this time? And I've removed one really. And I don't think I am particularly technical in the presentation, but I am happy to kind of do a technical deep dive and answer people's questions in the second half of this. So let me introduce myself briefly. My name's Owen Johnson. I'm an associate professor at the University of Leeds. I work in AI and medicine. I've done different things in digital health for 20 or more years, including running quite a successful spin-out business that was behind Test and Trace and connects all the UK's pathology labs to each other. So I've had a kind of been there as a kind of commercial supplier, developed software products. I run a centre for AI medicine at Leeds, and I run a Masters by Research for NHS England staff currently. But my big thing, what I do in my research and in my fun is process mining. So I was going to talk about the process mining work that I've been doing, in particular on some pilot projects which I've just completed for NHS North East and Yorkshire. And I appreciate we're at the other end of the country, or most of us are. But I'm hoping that the pilot examples I've done in the Yorkshire region will be interesting and inspiring, and I can kind of talk through the technical stuff of how we did those second. But I wanted to just, in this session, just focus on results. So that's the overview. This is my agenda from the January talk. So if you were at the January talk, fantastic, and the fact that you've been there and you come back again, I would take as a good sign. So in that, I talked about the second bullet point: process mining acting as a bridge between data science and process science. So I'll just revisit that bit briefly, and then I will give some fresh examples of process mining that you didn't see last time because I hadn't done them then. I will come back to the ClearPath method, which is the methodology that I developed for process mining in healthcare. Okay, so this is just a recap for those people that saw it last time, or a little bit of an intro for those people that haven't heard of process mining much before. So you can see process mining as a bridge. So this is this nice blue area in the middle. I guess most of you on the call would describe yourself as data analysts or data scientists. You are well used to using a range of techniques in your arsenal, and I'm sure keen to develop a whole range of additional techniques within the data science sphere. Process science is maybe the realm of some of your colleagues. You will have, I'm sure, teams in the hospitals and provider organisations that you're in that are doing process improvement. So process improvement teams might well be mapping out pathways. They might be doing some kind of time and motion observational studies, interviewing people about processes with the hospital, and they'll probably be coming to yourselves for metrics, and they'll be coming and saying, well, how many people were in ED last month? Is it going up or down? You know, what are the busy times of the day? So I'm guessing that there is already, in most trusts, a discussion between the process improvement people and the data people about processes. And process mining really is properly joining the two together. There are a range of tools which I will demonstrate, which empower a data scientist to help a process improver, or the other way around, are a whole load of ways of visualizing processes so that you can improve them. And so I kind of hope that when you are having conversations about how do we make our hospitals and care providers better, this is kind of useful stuff. So that's the context. At its simplest, if you saw this before, you know this. We take something like an EPR, any kind of information system, the data that goes into that, and we're particularly interested in three data fields: a case ID, a timestamp, and a title for an activity. And so those three ingredients are the only three things we need for process mining. There are some clever things that you can add on to that, but just those three. So the challenge then is, what are these activity names and can we get timestamps? In most cases in healthcare, we would expect the case ID to be the patient. Not always. If it's a hospital, it might be a hospital admission, or it might be an episode of care, in which case patients might have several, but we kind of often want to look at the admission or the episode, but either an episode or a patient ID. And then timestamps, which are kind of like a fingerprint of what's happened to that patient over time. And the aim is to use software tools which will take that activity log and produce the kind of process models that a process improvement person might be very interested in. So that's its simplest. There is a kind of reality gap between what we can do in terms of modeling pathways and what real healthcare looks like. If you look really carefully in the middle of this crazy ED department, somewhere in there, you'll see that there's a computer. And on that computer will be an EPR or something similar, and there will be people typing in. All we've got as data people is whatever was typed in. And we know from having been in healthcare organisations for a long time that what's typed in and what really happens is a big gap. So we're going to kind of start with the fact that there's always going to be a gap between reality in the ground, as is, and what we like to imagine is happening from the data. And our kind of job is to kind of understand what that gap is, and maybe where there are data quality issues because people didn't type something because they've written it on a paper form instead, and maybe typed it in a bit later, but maybe changed a few things and put a different date on. So I am an academic. I have two theory slides, so apologies in advance for those, but I hope these are light enough as theory slides. The first theory slide, if you like, is making the obvious point that healthcare is a complex system, arguably one of the most complex systems in the world, compared to any other industry, because the product that we work with is human beings. The patients are entirely able to do whatever they want. They're not the same as widgets going on a factory line. So if we start by understanding that healthcare is complex, the simple model of input, process, output, which it's kind of in most management theory, just doesn't work. We still need to use the terms and we still talk about this, but the reality is any complex system, the relationships are non-linear, as in more money in does not lead to better results out. Somehow healthcare systems hang together in lots of amazing ways. So I've got 4 techniques, of which process mining is the one that we'll focus on today. I will mention process simulation a little bit. Process improvement I've already discussed. And process modeling is the typical tool that process improvement people will do. And that's kind of sticky notes on a whiteboard or diagrams and drawings of what they think it is. If we take all these 4 techniques as a set of tools that within our healthcare systems we ought to be able to use to work out how to improve our processes. That's the first theory slide, so hopefully not too scary. Second theory slide follows that on a little bit more. This is something called Leave It Diamond, and it's very simple model, and obviously very old, 1965, but it's taking that same concept of the messy reality of healthcare delivery and explaining it a bit better, in that it's saying that there's four components of any organization. It's organizational structure, the technology that it's got, the processes it's got, and then the people. And what this diagram tries to show is that if we change any one of these four elements, it will have an impact on the other three. So changing the organizational structure will change the technology, it will change the people, and it will change the processes. But then there's a ripple effect, because if you change any one of these, it will have an effect on the other three. So you can imagine a mental image of healthcare where people are changing all the time, processes are changing all the time, structures and technology are changing all the time, and every change is affecting the other three in a constant battle of trying to find stability. And the miracle is that it does find stability, and that we do have healthcare systems that amazingly work despite all this dynamic internal behavior. What we've got from our side as data analysts is the systems and the electronic patient records that are coming out of the tech end being put in by people, and we think hopefully reflecting the processes that we should be able to see. So that was my kind of theory element, and what I wanted to do next 15 minutes is just give you some overview of 3 pilot projects that I've been working on with the North East and Yorkshire. All of them are motivated by optimizing EPR pathways. The brief from NHS England has been productivity. Please, productivity, 2% per annum. Everyone's got to do it, and they're obviously being driven from on high. They're being driven by the NHS 10-year plan, and so our job, yours, mine, everybody's job over the next few years is going to be trying to help identify productivity improvements and measure them, and that should be seen in reduced waiting times, better patient outcomes, hopefully also better staff well-being, which I think I'm pleased to see increasingly on the agenda. So what we've done over the last few months is look at some volunteer projects from volunteer sites. We've looked at Barnsley Hospital's A&E pathway. I've looked at a community inpatient group, inpatient unit, which is a bit like a care home, but for a short period of rehabilitation. And that's in Grimsby. And then we looked at 2 different memory services in Barnsley and Kirklees that are run by the same organisation but operate differently. So I've deliberately chose a few different types of organisation. So I'm going to show you, I think we've said all that. I'm going to show you the vision. So the vision would be that our clinical teams who are using EPRs are getting on with the job and hopefully feeding the EPRs reasonably well. There is a kind of workforce stress issue that clinicians and administrators often feel that they're feeding the beast. They're putting data into an EPR without necessarily getting much value out. So the aim of the project was to try and explore how we can create a learning loop where the patient records that clinicians are feeding can inform operational review, dashboards, team presentations, anything that can help those original clinical teams review their performance and understand what they're doing, and figure out how to be running their processes better. So I would like to see information flowing back to the people that put the information in, so they can see the benefit of their own work. So that's the vision. The technical workflow below that is those databases below the electronic patient records will be relational. We need to take date timestamps and activities out of those, create activity logs. with process mining tools, we can take those activity logs and produce process models. And then I'll give you one example where we've taken the process models and put them within a dashboard, which is implemented and live with process view of what's going on. So that's the vision. In the projects so far where we've done, we had a kind of 3-month project. We spent far too long doing data governance to get anonymized data out. That's because I'm in a university and not in a trust. If you were doing this work with your own data, you can bypass that step, I hope. Data extraction, technically, whoever's got access to the database needs to be able to pull out of the database relevant data and make that into event logs. I've spent some time rewriting bits of Python code to take spreadsheet data and all sorts of forms into a processable event log, then putting it into models. And what I've been doing with the teams at the 3 sites is just generating insights and ideas. I'll talk that through a bit later. And then we Barnsley Hospital built a dashboard, which I'll show you. Okay, so I was going to focus on Barnsley Emergency Department first, and I'm just going to try and do these quickly so that I've got enough time for Q&A, because I think the Q&A is the useful bit. Okay, so I had 2 years worth of data from Barnsley, 2 calendar years. They've got a care flow system. It's got its limits. I had no order comms, for example. But I got all the data for 2 years out of Barnsley ED. We spent several months calibrating the process models to their view of what the flow should be. And we were able to produce some high-level variants and then dive deep into those. So I'm just going to show you what we did. So this is a product called Disco. Bear in mind, I've taken the whole of 1 year's worth of data, fed this into the tool, and you can see that there's 2 ways into the ED, walk in an ambulance. There's 3 ways out. These lines are the total number of people in 2025 that went through these routes. So we're talking about 100,000 patients in here. And then this view, same data, but here's the median time for each of these 6 paths. So that's what I'd done there. All I did was exclude the 1% of rare cases that either unusual or data quality or whatever. So I got a nice simple diagram just by taking off the very tiny tail of 1%. Okay, second thing I wanted to show you was the activity coverage. You can see that all patients went through the kind of standard process of triage and assessment through to registration, arrival, registration, departure. But you can see ED, minors, majors, etc. What I want to show you is this, because this is sadly typical of ED departments everywhere. This is the 4-hour wait peak and the cliff edge, and then the long tail. You can see that bang on 4 hours, up to 75% of people get seen. You can see that it jumps very close just before the 4-hour wait. That's because alarms go off and things ping, and they run around and try and get people that they can within the 4 hours. Sadly, if they're not done within 4 hours, 25% of people have this very, very long tail. And you can see how long this tail is. That's 4 hours, so that's 8, 16, 12, 16. We're talking about some people that are waiting a very long time. So that's a perverse behavior as a result of a target. Interestingly, is that the way we want to run an ED is a good question. So here is the breakdown. The left-hand side is the basic pathway through in terms of total numbers. The right-hand side is just taken that by time. So we're interested in the thick lines and what times those are. So you can see I picked out the kind of 3 major steps. There's triage, median of 10 minutes, great. Long tail, that's fairly typical curve. Initial assessment, a lot of people done very quickly, but then a kind of fatter tail. And then EDs right through to ready to proceed, which is the other kind of major one. So we're able to kind of look at the median times and the profile of these. Where you go with this in terms of conversation with a process improvement personnel, we can maybe talk about in the next stage. Okay, so I'll show you a few more artifacts and then do the other case studies. So this is the full picture of all of the data from Barnsley ED with all the data quality issues in and the complex cases and unusual behaviour. So one of the first things I do is I spend time discussing with the data owners and the process owners to understand why we might have, say, 17 people. One person's walked in twice there. So what is that? Just a data quality error, or did they wander off and come back again? Can I get rid of it? And what I've done is I've trimmed that this diagram based on a conversation about is it appropriate to get rid of or simplify different things. And sometimes we've found data quality issues. Sometimes it's just complicated cases. So the final model, I won't walk you through this, but that's the final model for 2025. The left-hand side being a kind of frequency, the right-hand side being kind of time. What we also did was pin that to Barnsley's work doing some process dashboards. I'll skip through those. I just want to show you. I have not got them. So Barnsley team had built their own process models using R or BUPAR within their business intelligence dashboarding system and put those live with the 3 most common pathways. And brilliantly, and as credit to the Barnsley team for doing this, they created 2 views of the data. They created a location view and a decision view. And the decision view is about what are the clinical decisions and when are they made. And the location view is what are the physical locations that the patients are in as they go through the department. And obviously there's a connection between the two, but quite often if we're looking for speeding up clinical decision making, then we want to know the decision view. If we're looking at overcrowding, then we want to know the location view. So reflections from the Barnsley side, the 4-hour wait, this cliff edge and long tail, problematic. We've did quite a lot of work on this so far, but we're going to do some deeper dives looking at waiting time by patient time. We're also going to have a big talk in the Harrogate Hospital about replicating the same process and the same models that Barnsley has done and do those at Harrogate, see how transferable it is. Okay, right, last 2 examples, and Chrissy's going to try and make me finish in 4 minutes, so that's fine. So this is a CIU, community inpatient unit. This is kind of where people will come in, they'll spend a median of 2 weeks and then go back to a care home. So they'll either step down or step up care. So in an ED environment, you have a kind of patients come in and patients leave. With this, the process of admission and discharge is actually very simple. So here's the referral, admission, discharge profile. There you can see the kind of very unusual patterns in median time and median stay. What we did was we looked at 2024 versus 2025. You'll see huge improvements in the median time to admit and median stay reducing, which is better. Median stay reduction is good, lower, cheaper cost, but it also means people have recovered faster. When we played this back to the team, then actually a new management team had come in and made major changes. So this reflects management improvements that were implemented on site. All we've done is capture that and report it back to the team who did the changes, and they're obviously pleased to see that they'd done a good job. But they've not seen data like this. There are still problems. 23% of cases still stay longer than 40 days, which is an issue. There's 2% staying longer than 100 days, and that's still problematic, given that the aim is for everyone to be 20 days. Seasonally, this is the pattern of demand for new admissions. No obvious seasonal pattern. There's no winter pressure here. It's kind of over. So this is 2-year period. And similarly with referrals coming in, that's one, 2 or 3 referrals per day, or none. Again, pretty constant throughout. Capacity wise, they've amazingly run just below capacity. When they've had these troughs, it's because they've had to close beds due to infection control. So actually really, really well run unit, I think. I mean, I'm not able to identify much other than that they're running the unit really well. We were looking at things like dynamic time warping to understand, are they as good over the weekend? So we've got some more work to dive a bit deeper with them. And in particular, we're going to look at the form signing and the form process for the admission process. There are about 14 forms that they fill in as part of the admission process. Some of those forms are risk assessments, some of them are physiotherapy planning, nutrition planning. Ideally, all of that would be done very quickly so they can get on with treatment, but it's taking up to 48 hours to get them done. So we're trying to try and understand what are the process bottlenecks in that step. And I'll skip the reflections because I think I've covered those. And the last one was South Barnsley, Kirklees. It took us nearly 3 months to get the data. The data's got serious data quality issues. So we are able to kind of pull off summary data, but the coding on this data is really poor. If I give you examples of general medical practitioner, XTGP, so that the general, just something as simple as a GP is there several times, carers are there several times. All these small codes were historically used earlier in the IT system, and they've gradually got better at standardizing on standard codes. But it means that any analysis has to start by an awful lot of tidying up historic coding. But we're still able to kind of look at the way that compare Barnsley and Kirklees in terms of their processes, referral times to diagnosis, and the way that the 2 units are operating differently. So I'm going to skip past that. We've got a new data set just arrived, and we're going to map that. So this is the process improvement mapping. You can see they've put lots of question marks about what the times are between these steps. The next stage in our project with these guys is taking the data and trying to answer the question marks in their process improvement mapping. Okay, so I think that's it. I'm going to finish by saying that at the moment I'm doing what's called an academic fellowship. So I've got 2 years of which I'm halfway through. So I've been working on process mining case studies, of which I will write these up or do a bit more work with them than write them up. And I'll make them available to people as kind of exemplars of what we think can happen. I ran a big international workshop on process mining for the NHS earlier in the month, and I've got a new guy called Anthony Lee joining me. So we're up for helping you guys. So if people are interested in doing this and would like support, we are very keen to do that. There's also Tim Greatrix, Adrian McCluskey and others, part of the NHS England process mining team. And I think you might have met them. Some of you will have met them previously. So we have between us a lot of capacity to help support exemplars. We will be running some training courses in Leeds, and I can make sure that the details of that are available. It does mean travelling to Leeds, but I mean, if people are keen to do that, and then we're in discussion with the Digital Academy to turn that into online training material. Okay, I think, Chrissy, shall I stop at that point and switch to kind of technical discussion?